Hi, my name is Sarah Ramel, and I'm a neonatologist and associate professor at the University of Minnesota. Today's course is just one in a series of subjects brought to you by Channel 1 On-Demand Nutrition Education. Today we are looking at body composition growth curves for infants. Early growth matters for babies born at all gestational age and sizes. However, the risks and benefits to slow or rapid growth are different for each group, likely secondary to different critical windows for brain development and cardiovascular risk. For preterm infants, early rapid growth in all compartments is associated with improved neurodevelopmental outcomes, and thus far, early research suggests that when it occurs prior to term, it's not associated with significantly elevated metabolic risk later. For term infants born small for gestational age, there appears to be some neurodevelopmental benefit for faster growth, as shown in this figure, but also increased risk for later metabolic disease. For term infants born appropriately sized, there does not appear to be a neurodevelopmental benefit for increased weight gain after birth, but metabolic risk does increase with excess weight gain. A growing body of literature suggests that quality of growth may be more closely associated with long-term outcomes for preterm infants, especially, but also for term-born infants. Typically, body composition is broken down into two main compartments, which include fat mass and fat-free mass. Our group, as well as several others, have found that fat-free mass is more specifically linked than weight gain to improve neurodevelopment in multiple domains, including standardized developmental scores, speed of processing, and working memory. While fat mass gains are more specifically associated with increased metabolic risk in both term and preterm infants. Other groups have also found that increased fat-free mass and lower fat mass are associated with improved mental health outcomes for term-born infants. With increased research showing the potential benefits of early optimization of fat and lean mass, as well as advances in technology, routine tracking of body composition with the goal of optimizing nutrient intake, growth, and in turn, long-term neurodevelopmental and metabolic outcomes is becoming more common. Ideally, clinicians would be able to utilize measures of growth already collected to gain a better understanding of body composition and quality of growth. BMI and other proportionality indices have been proposed and are routinely tracked in most units. Additionally, there are preterm and term infant curves that have been developed to track BMI over time. Unfortunately, through a series of studies involving more than 500 preterm infants at various ages who underwent anthropometric measurements and body composition measurements using air displacement plethysmography, we found that these measures are overall poor predictors of whole body composition. With regards to fat-free mass, weight is an adequate surrogate early in the lives of preterm infants, but becomes much less so as they gain fat mass throughout their NICU stay. When looking at the ability of weight for length indices to predict adiposity, we found that at least from birth to 63 weeks corrected age, no index was an adequate surrogate for adiposity or percent body fat. The Intergrowth Project performed a similar investigation for term-born infants and found that weight for length was a reasonable predictor of fat-free mass, however, not as good at predicting fat mass or adiposity. So for this reason, we need measurement techniques that allow us to track body composition early in life and throughout childhood. There are many methods currently available to measure body composition in infants. Here are a few that are currently validated, feasible, and used. However, there are very few that are currently validated, feasible, and used regularly to track infant growth. MRI and DEXA are both direct methods of body composition measurement that are accurate and precise, but given the expense, need to limit movement of infant during the study, need for transport to radiology and trained technicians, exposure to small amounts of radiation. With DEXA, they are more useful for research quality data, but unlikely to become routine nutritional management tools. Skin fold thicknesses have been used to estimate body composition by taking multiple measurements at various body sites using calipers and then associated with whole body fat mass using prediction equations. These measurements are inexpensive, non-invasive, but may not reflect the whole body fat because they only measure subcutaneous adipose tissue. Bioelectrical impedance is widely used for body composition assessment in older children and adults, as it is non-invasive, portable, and does not expose the subject to radiation. However, it also relies on several population-based assessments, which may not be true for neonates and require a stable hydration status. It's also sensitive to infant movements and may be sensitive to feeding time prior to measurement. Thus far, bioelectrical impedance has not been shown to be accurate or precise in small young preterm infants. However, over time, if those assumptions could be adjusted to fit this population, it could become clinically useful, given its portability and price. Ultrasound is a developing method for assessment of body composition in infants. Images are analyzed for either adipose tissue or muscle thickness or cross-sectional area. Ultrasound is currently not utilized routinely for assessing body composition in any population, but several studies have shown it as a promising method for the future. It has been minimally explored in infants. Finally, the P-POD, which uses air displacement plethysmography and has been validated for infants 1 to 10 kilos, and the BOD-POD with pediatric option, which has been validated for children ages 2 and up. This is the method we've used in most of our studies and also that used in the majority of other publications. This method is easy to use, does not expose infants to radiation, and is not influenced by infant movement. It is tolerated in infants as young as 29 to 30 weeks. However, the biggest disadvantage is that infants must be able to remain stable on room air without respiratory support or IV lines for about 5 minutes. The equipment is large and expensive, and between 6 months and 2 years, these methods are unable to be used. While there are a variety of options for body composition measurement in older children and adults, and many of these techniques are emerging as potential options for infants, ADP is currently the best option for routine body composition measurement in the first 6 months of life. In order to utilize these measurements for optimization of later outcomes, we must have references or standards to compare measurements between infants and across studies. Currently, these are only available for ADP, and I will run through what is available now and how they can be used. This set of body composition growth curves were created from the Intergrowth Project, and they were published in 2017. They're considered a growth standard as they were created from an extremely healthy population and intended to represent ideal growth of the healthy fetus, which the AAP suggests is how preterm infants should also grow. These charts were generated using a prescriptive subsample of almost 250 infants from the larger Intergrowth study who met very strict criteria, such as having an early confirmatory dating ultrasound, normal maternal BMI without maternal comorbidities, infant being born at term, appropriately grown, and healthy enough to be measured in the first few days of life. The data was collected cross-sectionally, with each infant being measured with ADP once shortly after birth. These types of charts could be used to plot healthy term infants at or shortly after birth and compare them to other healthy infants, or potentially also used for formerly preterm infants when they reach term adjusted age to see if they have achieved the AAP goal of growth, similar to the healthy term neonate. In 2019, we also published a growth reference for use in the first 6 months of life using pooled data from 4 studies. We also utilized air displacement plethysmography to measure infant body composition. This project generated 3 sets of charts for each sex and body composition measure, including fat mass, fat-free mass, and percent body fat, that can be used from 30 weeks gestation out to 41 plus 6 weeks gestation at birth, and from 1 to 27 weeks postnatal age. These charts were created from a much larger sample when compared to the previously mentioned charts, but did have less strict selection criteria for the reference population. The first type of chart shown on this side used all measures performed cross-sectionally at birth in both preterm and term newborns, similar to the previous chart. 222 preterm infants and 1,029 term-born infants born in Ireland were utilized for this set of curves. All measures were obtained in the first 72 hours of life and again meant to represent healthy fetal growth. Therefore, these charts could be used to track growth over time for preterm infants and at birth for term infants in order to compare them to other healthy fetuses or infants at a similar gestational age. Term infants whose birth weights were less than the third or greater than the 97th percentile on the intergrowth 21st standard were excluded, as well as preterm infants who were below the 10th or above the 90th percentile based on the Fenton curves. Infants also needed to be singleton and able to be measured within 72 hours of birth, requiring even those preterm infants to be off of respiratory support and able to tolerate not needing an IV. The second set of charts from our study utilized longitudinal data from the Rogero, Italian, and Fields U.S. studies, including a total of 200 infants who were measured between 1 and 8 times in their first 6 months of life. No birth data were included in these charts, and measurements had an intervening period of at least a week between measurements. These two studies shared the same study design and were combined of term births between 37 and 0 and 41 plus 6 weeks of gestation. They used criteria adapted from the WHO Multi-Center Growth Reference Study, including singleton birth, non-smoking mothers, exclusively breastfed infants for 6 months, and no significant perinatal morbidity, again in order to attempt to represent optimal growth and development. These charts would be best used to compare and track healthy term-born infants, growth and changes in body composition during early infancy, and also to investigate outcomes associated with growth during the time period between birth or term gestation and 6 months postnatal. The final set of charts is a combined and smooth set of curves allowing tracking of growth and body composition from birth out to 27 weeks postnatal age for both preterm, after 30 weeks, and term-born infants. The associated LMS values and statistical code published with these charts allow clinicians and researchers to calculate z-scores to compare the growth of an infant to that of this large cohort of relatively healthy AGA preterm and term-born infants born in the US and Europe. Given that our charts are based on data from 4 studies, we were able to include a much larger sample size compared to the intergrowth charts. Although the included studies did have distinct inclusion and exclusion criteria, each study attempted to select a sample representative of a healthy population and therefore reflect the recommendations of the AAP and WHO. So the ease of use, safety, and ability of air displacement plethysmography to provide valid and reliable estimates in combination with the availability of these standards and reference charts makes the reality of incorporating body composition measurement into the regular nutritional assessment plan of high and low risk infants a much more real possibility. However, what remains largely unknown is the ideal or optimal body composition of the infant. Finding a suitable method and developing a set of references and standards are the first steps, but in order to determine this, long-term studies measuring both neurodevelopment and metabolic outcomes are needed. I'll finish this talk by referencing just a few studies that have started to look at this, but more work is definitely needed. This was a relatively large study out of France, enrolling over 150 infants born before 33 weeks gestation. These infants all underwent body composition measurement at hospital discharge and were brought back at 2 years of age, where their parents completed the Ages and Stages questionnaire. They looked at multiple birth characteristics and growth outcomes to determine which ones were associated with later neurodevelopment and found that gestational age at birth and fat-free mass z-score at discharge were the best predictors of later neurodevelopment. Specifically, fat-free mass z-score was a better predictor of the outcome than weight z-score at any time point. We performed a similar analysis, again using body composition z-scores at hospital discharge and also at 4 months of age in over 100 very low birth weight preterm infants. We examined whether body composition z-scores at these 2 time points were predictive of neurodevelopment measured by the Bayley scales of infant development at 12 and 24 months. Similar to the previous study, we found that fat-free mass Z-scores at hospital discharge were associated with higher cognitive and motor scores at 12 months and improved language scores at 24 months. We found no associations between fat mass or percent body fat scores, nor any association with 4-month Z-scores and later neurodevelopment. This study out of Harvard, a group of preterm infants underwent body composition testing and brain MRI to look at associations in brain size and growth in body composition at term-corrected age. Increases in weight, head circumference, and BMI Z-scores, as well as the amount of fat-free mass present at term-corrected age, were associated with increased brain volumes, while fat mass gains did not show those same associations. Additionally, they found associations between higher fat-free mass Z-scores and overall brain volume, cerebellar volume, and white matter volume and microstructure. This study highlights that fat-free mass is a marker of both improved brain structure as well as function, as highlighted in the previous studies. This final study also investigated associations between body composition and brain size. In 118 preterm infants, they similarly found that fat-free mass Z-score was significantly correlated with larger brain size on multiple measures, while fat mass Z-score was significantly correlated with lower brain size. All of these findings remained even after adjustment for multiple covariates. So for both structure and function, it appears that the addition of body composition measurement to regular growth assessment may provide additional insight into long-term outcomes and may be an important target for interventions in the NICU. In conclusion, early growth matters for all infants, and tracking of growth quality through measurement of body composition may lead to an improved ability to predict and optimize long-term outcomes. While technology is evolving and there are many new techniques emerging, air displacement plethysmography is currently the most feasible and accurate technique for measuring infant body composition in the first 6 months of life. It's also the only method for which standards and reference curves currently are published for infants. With continued research utilizing these techniques and charts and measuring long-term outcomes, we may be able to define the optimal infant body composition and in turn develop interventions aimed at achieving this ideal growth pattern. Thank you so much for listening. I invite you to watch for upcoming Channel 1 videos on nutrition and learn more from my esteemed colleagues. Have a great day.